Hey guys, Kim here, and you are tuned in to Kim E, the Diabetes MP, a place where healthcare professionals can come learn more about diabetes care to improve their patient outcomes. Now, we've been on a roll here. We've been talking about the older adults and diabetes because May is Older Americans Month, and I felt like it was only necessary to discuss this since this affects so many people of the older adult community. We've already given just a little good overview of it, as well as we've talked about the SDOH that's unique to that population. If you haven't caught those videos, I'll link them in the description box. But today we're going to talk specifically about education, talk a little bit about diabetes self-management education, and let's get right into it. So education, let's really talk about this and kind of just really unpack it a little bit. So with this population, you will find yourself probably having to dispel a lot of misinformation because you're dealing with people who have a lot of years and have then acquired probably a lot of misinformation. They have seen family members with diabetes, they have seen friends with diabetes, and when people think of diabetes, quite honestly, it's like a cloud has entered the room. And a lot of times when people think of diabetes, they think of insulin, they think of amputations, they think of dialysis, and it takes a lot to get there. You know, if I could get a quarter for every time I've heard somebody say, you know, my auntie had to lose her leg and I don't want that diabetes, you know. That's a common thing. People, it's like there's no middle ground. It goes from 0 to 100 real quick for people. So you have to let people know that, let's talk about this a little bit. Maybe your auntie was told she had diabetes, but never took her medicine. Maybe your auntie never knew she had diabetes, you know. Because again, with the older generation, one thing that I have found, especially when I'm doing like family history, older generations didn't really talk about their health. A lot of times people don't know what their parents had. And this whole idea of really talking about your health and being educated on your health, it's really kind of a newer idea because for me, I'm in my 30s, my late 30s. My grandparents and my great grandparents, they didn't really talk about their health like that. And so with that being said, you're going to find that a lot of your patients probably don't feel very comfortable talking about their health. But then their parents and their grandparents definitely didn't speak about it. A lot of times people didn't know folks were sick until they died. And so, and then they just kind of assumed that, well, we think, and then a lot of people didn't get autopsies, so you never really knew why someone would pass away. And so you're dealing with a lot of trying to see where people are with their education and what they know about diabetes, and then also their feelings about it, and then really trying to pull it all together for them. And there's many different ways that we can do that. Of course, I am a big advocate for diabetes self-management education, support, training. Depending on who you're talking to, you're going to hear different terms. But that is a formal program, okay? You yourself, when you're giving education, you're not giving DSMES. You are just giving education. But that is a whole program that can come with medical nutrition therapy. And again, you talking to your patient about food is not medical nutrition therapy. It's a formal program, you know? And the unfortunate thing about these programs is that, especially DSMES, you do not find many programs. There should be far, far more programs, recognized programs than they are. And when you start thinking about the person who has limited transportation, when you start thinking about the person who lives in rural America, they may just not have the access to it. So you do have to get creative at this point. Coverage is not always the best. During COVID, there were some exceptions for telehealth, but with the DPP, which is Diabetes Prevention Program, you can do that online. But the DSMES it's a little tricky there, and it's a whole beast of its own. So I won't get into depth there, but I do want to mention that that is available, and it is a great resource. And all patients should go through it. All patients should have medical nutrition therapy. There's lots of guidelines of how many sessions they're supposed to have to be able to get it covered, and there is qualifications who would qualify for that. And a person doesn't go through it every single year. It's like a one-time thing. And so if you're interested, I will link some links down there so you can look that up for yourself and for your population, because it's different. You may have a program that's at the local hospital, and that's great, but then you may not have that. And so we have to get a little creative with that. The biggest thing that I do want to address when it comes to diabetes education, which is something that these things that I'm going to mention, they are components of DSMES. So if for the person who is new to that or doesn't know how to go about that, where do I start? Again, like I said, get your patients into DSMES, get your patients in MNT. It's proven, and it just is good, okay? This is what your patients need. And the standards support it. It says that every patient should go through these programs. It's just that the reimbursement and the access is not always there. But anyways, if you're saying, I'm new to this, but I don't know where to start, where do I start? Well, of course, lifestyle modifications, and specifically weight management, as well as nutrition, okay? Now, I've spoke about this before, and I'm gonna say it again. One of the spills I've overheard many providers, and at one point in time, I used to do this myself. When it comes to educating your patients, we'll say things like, make sure that you're working out, make sure that you're getting your exercise, and make sure that you're eating good. We do not take a lot of time, and I understand because we don't always have the time. But this is why you got to be creative, right? Maybe the education you need to teach your MA, or maybe you need to teach your nurse that works there to do a more intensive, education. Maybe you should have, handouts that go a little bit more in depth so the person can go home. Maybe you should go home and read it. Maybe you should make videos. Maybe your clinic can make videos that they can view. I don't know. This is where thinking outside the box helps a lot. But when it comes to weight management and nutrition for the older adults, you really have to understand who you're talking to, okay? One thing that I tell all the patients that I see is that exercise does not, or physical activity, okay? So physical activity is the big umbrella, and exercise is a form of physical activity, okay? But when we talk about physical activity, people always think about exercise. Physical activity could be yard work. If you have a patient that mows their own yard, they cut their own bushes, they plant their own flowers, they have a garden outside, all that stooping down and getting up and lifting flower pots and getting mulch and all that stuff, y'all, that's the equivalent of like lifting weights in a lot of cases. If a person is able to do that, that's giving them that bone exercise that they need, that weight-bearing exercise. It definitely is going to take a lot of balance, which outlined by the ADA standards of care is what they're going to need for older adults. Like you cannot discount that. And so talk to them about what they're already doing. If they babysit their grandkids and they're active with their grandkids and they're out in the yard, throwing a football with their grandson, that counts for something. Grocery shopping. I tell people, get your steps in. Take the stairs when you can. Don't park so close when you're in a parking lot. Make sure, I've even had patients to say that when they go grocery shopping, they walk the outside of the store. Well, they walk, like, clearly they're inside, but they do the outer side inside, and then they go up and down the aisles. That's exercise. That's walking. You know what I'm saying? And so there are many mall walkers. like people that get into groups and walk at the park with their friends, you know, really try to show them that they may actually be doing a lot of good habits, and how can we kind of up it a little bit, you know what I'm saying? And some people, they don't have to up it, but you do have to take this stigma away that physical activity is in a gym, on a treadmill, running, on an elliptical. And if that's what they want to do, that's perfectly fine. Many of the Medicare plans allows them to do like silver sneakers and pays for a gym membership. Their insurance will pay for a lot of that. You definitely want them to do that if that's what they feel like they can do. But if you have a person who does all this other stuff, like, this is where a conversation will come up, okay? Also, when it comes to nutrition, please keep in mind that it is also culturally appropriate. I have gone behind providers who have taken care of, I'll give an example, a Mexican patient. And this Mexican patient was told to not eat tortillas or rice, when this patient, in fact, eats tortillas and rice for breakfast, lunch, and dinner. Of course, other things as well. But my question to them was, did your provider ask you what kind of food you eat before they started taking things away from your diet? And the person was like, no. So think about that. If you have a person who primarily eats a certain thing for every meal, and then you say that they can't eat it at all, what do you think is going to happen? Do you think they're going to listen to you? Probably not. Because you've just basically, to them, they're going to say, what am I going to eat? Ice? You know, what am I going to eat? You've taken away everything that I eat. So really having a real conversation about what are the things that you tend to eat for breakfast. Tell me what you typically eat for breakfast. Tell me what you typically eat for lunch. Tell me what you eat for snacks, dinner, all that stuff like that. And then what they tell you, you then go in and individualize it and then also customize it. Okay, maybe you don't take everything away. Let's don't take everything away cold turkey. Maybe it's, let's take away this. Instead of eating this type of tortilla, how about you eat this type of tortilla? Instead of eating the refried beans, how about you do black beans? Okay, it's really that simple. Because you don't want to leave your patients hopeless. Because if they're hopeless, they're going to do what they want to do. Okay, give them hope, give them motivation, right? And this is just real quickly, lastly, smoking cessation, okay? This is something that is one of the components that is addressed in DSMES, is smoking cessation. This helps multiple things. If of course, it'll help your heart health as well. But this is a big thing as well that we really tell all our patients is to quit smoking. Okay, guys, that's all I have. Again, please check the description box because I have a lot of things down there that you can do some more learning, some more listening to, reading. If you need extra reading and extra resources, check the description box. Again, thank you for sitting here with me as we go through this. If you haven't already, please subscribe to my channel. Click the notification bell, like the video, please. It helps me to know what you like and what you don't like. But again, you have been sitting here with Kim E, the Diabetes NP, and I'll catch you on the next one. Bye.